Good morning, everyone, and welcome to EuroNurse. We meet live every Saturday at 9 a.m. Central Daylight Time. Won't be daylight time for too much longer, so Central Time coming up soon. If you're watching us on YouTube, great. Appreciate you seeing us over there. If you want to learn more about the show, I welcome you to come to our website at euronurse.com, where you can get more information about the program and things that you can register. And if you want to ask questions, you have to be on the Zoom as a registered attendee in order to ask questions. So I do welcome you for that. Our format is going to be general questions for the start of the program. We'll take as many questions as we get. And after we get our questions answered, we'll go on to our first presentation, or our only presentation, which is going to be erectile dysfunction. This is part 2. So I'm looking forward to talking to you guys. I'll be the speaker for that. We have a great group of panelists here today. So we're looking forward to working with our panelists. I have Andrea Strong on today, and I think we're about ready to kind of get going here and talk about a few things. So I'm going to start off with introduction for Andrea, and she's going to talk about next week's, a little teaser, what's going to be our presentation for next week, which is called Urology Part 2. Go ahead, Andrea.
All right, so Urology 101 Part 2. This presentation is designed for novice nurses, medical assistants, all the way up to the experienced nurse or nurse practitioner. We're going to be talking a little bit about external catheters, which are like your condom catheter, your Texas catheters. If anyone is a what do they call those? WIC, the female catheters. If anyone has a lot of experience with that, please join us next week. I don't personally have a lot of experience with the pure wick, that's the name of it. So I'd be curious to know. We'll talk about suprapubic catheters, suprapubic catheter changes, and some of the specialty catheters like the green silastic catheters, 3-way catheters. And I hope that I can provide you all with some new information, and I love it when the participants also provide new information to us. So looking forward to seeing you all next week.
Oh, great. So if you have any questions, feel free to go ahead and add those in now. We'll be taking general questions, but until we get some questions going here, I do have some information I'd like to share with everyone. On November 19th, the Chicago Metro chapter. Now, Chicago Metro SUNA is one of the biggest contributors to sponsoring the webinar costs so that we're able to put this on every week. They're going to be having their big conference on the 19th at the Sheridan in Lisle. If you're in the area and you haven't signed up, go to our euronurse.com website. There is a link that'll take you there. It's going to be a great conference. Male infertility, treatment and surveillance of kidney stone disease, minimizing the risk of malpractice. Now, that's a good one. And pessary is always an interesting subject. So got some great speakers. I do invite you to to come to it. I will tell you that we do have a lot of great upcoming events. If you go to our website, there's a calendar, and you can look and see what the next event that's going to show is going to be. I think that we're filling that calendar out. And at this point, I will say, if you're interested in becoming a panelist, don't be afraid to become a panelist. We're looking for people that are willing to share their knowledge. So we're looking for experienced people. Don't have to be advanced practice, but somebody who's had practice experience, so that you can help to share. Because I think the unique thing that we offer is a perspective from our long time spent in urology. So I do recommend that you go to the website and just go over here to this register as a panelist button, click it, and you'll be able to go over and just fill out some information. If there's a subject that you want to make sure that we don't miss, there is a survey that comes out at the end of this webinar. Go ahead and fill that survey out and just put any information that, hey, I'd like you to talk about this. I know a special speaker, somebody that you know that you think would be great. Let me know. I'll contact them. That's how we got Todd Thompson last week. One of the attendees sent me that information on him. So we're here to provide a program that I think you're going to find interesting. So we're trying to, make it as best for you. So let's see so the one thing I did want to talk about, I'm going to be trying something again, first time. We're going to try to do a event for November 19th is one of our EuroNurse days. So we're going to try to do a live event from that conference. not guaranteeing how things are going to work because I'll be working in between doing the conference and trying to set up Euronurse, but we're going to try. So from 9 to 9:30, we're going to just do a little run through the exhibit hall. And then at 9:30, we have a speaker who's going to be giving their presentation for an hour. Again, if you can join us live, it's a great experience. We have stadium seating. We have a huge exhibit hall where you can go and visit exhibitors. But if you can't join us live because you're too far away, then you might be able to enjoy us virtually. So we hope to bring that type of programming to Euronurse. I don't know. What do you think of that, Andrea? Sound like a good plan?
Yeah, that does sound fun.
All right. Now we're able to take questions. Welcome everybody. I see several of you joined it from before. I think there may be some new names here. I'm not sure. But if you have any questions, comments, this is your big chance. If you don't, we'll go right into our talk today. Anything that's on your mind, we're glad to answer questions. Otherwise, I'm going to start getting ready and we'll get right into our talk. So, all right. I don't think I see any questions coming in. So
Nope,
I'm going to
yet.
switch over here. So I need to. All right. And while I'm talking, feel free to use the Q&A button. If something comes up, I'll answer them at the end of the presentation. But if you suddenly think of something, hey, I want to really know about this, don't hesitate, put those questions in because the interactivity is the best part of this whole thing. All right. So today I'm going to be speaking on erectile dysfunction, part 2. I've decided to break this into 3 parts. The first part, let's see, I wanted to get this there. Get me on the screen here. I'm going to break this into 3 parts. The first part we already gave, that was the part 1, erectile dysfunction oral therapies. It also goes a little bit into the history of erectile dysfunction. So I recommend you can go back and watch it. It's our 8th episode. Go to the website and you can watch it over and over if you want. Anyway, that's the first part. I'm going to do the second part today, which I'm concentrating on penile prosthesis and on vacuum erection devices. And the part 3 will then look at the injection therapies and the intraurethral pellets. I think it's going to give us a little deeper dive into all those subjects. So hopefully this will be good. So I'd like to start off a little history, the evolution of the penile prosthetic devices. And so I was able to, in my research, notice that the earliest documentation of an artificial penis for medical use was the 16th century. And that was a guy by the name of Ambrose Paré. And he's credited, I hope I'm saying that right, I'm not French, is credited with making the first artificial penis from a wooden pipe for a patient to facilitate micturition. So it wasn't actually used for sexual intercourse, but it was the first attempt. And I tried to dig through the internet to try to find a good picture, but this is the best I could come up with of that first device. 1936 and 1948, Borges and Bergman both did some research on using rib cartilage for making the penis rigid. And although I thought it sounded kind of crazy that they would be using rib cartilage, I did some research, and actually there was quite a bit of things being looked at with rib cartilage and breaking it down to use as a matrix to build stuff on. So it was used. They reported satisfactory intercourse results 4 months after the completion of the procedure. However, the issue was it had a super high infection rate, which meant that it didn't last. And unfortunately, the material, the bone material, was reabsorbed over time. Now, most of the reports said that because of the infection, there was a lot of almost like Peyronie's curling of the penis and things like that and scarring, which made it useless. But at least there was, some thought going into it back then as to what they could try to do to try to treat erections. I was kind of surprised that it dated back that far. Now, in 1952, Goodwin and Scott reported on 5 cases with an acrylic prosthesis. The advantage was it's not absorbed by the body. The positioning that they did surgically, I don't think made a lot of sense. It was positioned beneath buccal fascia, and they had very few successes with it. But it wasn't until the 1960s that the space program developed siliconized rubber, and silicon rubber was then approved for human implantation. And that really is what spurred on and got the penile prosthesis that we currently utilize. And two new silicon prosthetic devices would be introduced. One was an inflatable penile prosthesis, and the other was the malleable prosthesis. And I'll talk a little bit about each of those and how they differ. So in 1967, Pearlman, described placement of a solitary silicon rod, again, between buccal fascia and the tunica albuginea. So right in there. Now, modern prostheses are placed inside the corporal cavernosa. That was until it wasn't done until much later. So that's the rod. Actually, this thing right here is the rod that was I was able to find a picture of the Pearlman celastic rod implant, and probably no surprise, it caused significant pain and long-term results were unsatisfactory. But at least we're getting on the right page and something that's not going to dissolve. Now, in 1973, Brant Scott and his Houston colleagues successfully implanted a device using a pump system with saline to achieve an erection. And I've got a picture of what that first design looked like. And, you know, for those that are familiar with penile prosthesis, the modern penile prosthesis, although it's undergone quite a few changes, the basic way it works is still the same. You've got a reservoir that holds the fluid, and then you've got some kind of pump device. In this particular one, they have two pumps that pumps the water from the reservoir into these rods that then are able to hydraulically fill with fluid, become firm, and are useful for erections. In 1974, Small and Carrion introduced the implantable silicon rod as a prosthesis. Now, this would be what we consider a malleable, malleable prosthesis, not an inflatable one. So this was placed, and then it was hopefully bent out of the way. Now, the only problem was that early prosthesis, the silicon was pretty stiff and didn't really allow for concealment. It wasn't until 1978 when Jonas came up with the malleable implant, and what he did is he put a silver wire inside that could be twisted, and then it would maintain itself, so you could bend it out of the way when you didn't want to have an erection and bend it up for use. And the modern penile prosthesis is very similar to that, so it's really kind of withstood the test of time. The Durophase, I included this slide for one reason. It's no longer available, and it was kind of an interesting device. So all these little things you see here are like little dishes in a row, and there's a wire running through here. And when you click the device, this wire would shorten, and these things would all stiffen, and it would make it into a prosthesis that could be used for intercourse. When you were finished, you just bent it like you kind of see here, that bend, and that would release that mechanism. And then these things would almost become like a normal penis, soft. Now, the only reason I included it is we had one of these in our office, and I used to just love playing with it, clicking it, unclicking it, clicking it. It was just a fun thing to use. We never implanted any in our practice. Again, they're not available. And the reason they didn't succeed, because it's not a bad idea. It's all in one, so you only have to implant those two things. You don't have pumps to implant and reservoirs. But they weren't very durable. That mechanism, the mechanics, playing with it back and forth, they break. Eventually, I broke ours too, by the way. In the US, the inflatable penile prosthesis became the most popular player. And I think it makes a lot of sense. It's just the most concealable, most natural looking. And the big major players are AMS, which was actually Boston Scientific bought them out, and Coloplast, which was formerly called Mentor. So two big players left in the penile prosthesis arena. So how does a penile prosthesis work? So as I showed in the early version, it's not much different. There's a reservoir planted somewhere up here in the abdomen. There's a single pump planted down by the scrotum. And then there's connecting tubing to these two cylinders. By pumping it, you can pump fluid out of the reservoir to fill the cylinders. So you can see that's the pump. Patients have to be instructed on how to find the pump, squeeze it. And then as they squeeze the pump, the fluid's coming out of the reservoir. We can see the reservoir up on the top. And it's filling up those cylinders. And it creates a fairly normal looking erection. And then when you're finished, this particular one, you just push the button and it allows the fluid to be compressed back into the reservoir. Some of them, you actually have to hold it. Slight difference in the two. And then it returns back to a normal flaccid state. So complications, probably no big surprise. Uncontrolled bleeding after the surgery, possibly even leading up to a reoperation. You know, the penis is fairly vascular and these rods are placed in through the corporal cavernosa. And you're going into the scrotum with the pump and up in the abdomen with the reservoir. Infections are always a big concern because if it gets infected, it's going to probably need to be removed. I can tell you that early on in my career, I was fortunate enough to get to go in and scrub it on some of those cases with our docs to see how the prosthesis was done. And I've been in, you know, several of the cases in the OR in my early career. And the one thing with penile prosthesis, they consider that like the most sterile technique possible. They would keep anybody out of the room. So once you got in the room, you couldn't go in and out. They wouldn't allow anyone else to come in and out of the room. Nobody circulating. The people in the room stayed in the room because they didn't want dust or anything to get in to try to be a risk for infection. So they were very careful about it. They took it serious. And their success rate was very good because of that. Scar formation, some scar formation we expect. We want that pump to scar down where we can use it, but you can get scars everywhere else. And erosion is one of the more serious things that can happen. Tissue around the implants can break down. And then like any other mechanical device, they fail. You know, it's just a part of reality. So if they fail, they're rarely repairable. So, and one of the things about penile prosthesis that I always warn patients is once you pick that option, that's it, because you've ruined pretty much ruined the corporal cavernosum. So a pill that comes along won't work. You know, the injections are not going to work. I have used some vacuum devices. I can talk about that if you want later on patients who had a failed pump that still had, you know, the fluid in the reservoir. You could pump it in that way, but the locking mechanism for the fluid wasn't working. So, but it didn't work very well. This is some examples though of erosion. So what we see right here is the tubing, actually the transfer tubing eroding through the skin. What we see down here is a picture of the actual pump that had eroded right through the scrotal skin. These are all going to have to be removed. This is kind of that worst case scenario where the two corporal bodies have eroded, you know, the prosthesis has eroded through and probably a little started gangrene there. This is not that uncommon. I've had patients come in and they say, you know, what are you here for? And he goes, well, I had a penile prosthesis and I think I see it. And this is what you saw. So, I mean, there was no question you could see it. And this is obviously pretty obvious. I like this picture just because it shows how the implantation, where it sits anatomically. So this would be urethra down here, and these are the corporal bodies. But I mean, this is obviously a bad situation to get into. So you don't want infections, and erosion is a big problem with them. So let's talk a little bit about post-op instructions. So we always warn patients that there's going to be drainage from the small opening located on your scrotum for probably about 3 days. Wear a pad to absorb this fluid. You know, I always say it's good to let patients know what can happen and what to worry about and what not to worry about, so they're not, you know, getting nervous. Big one, I always tell patients there's going to be a lot of bruising, a lot of swelling, and a lot of discoloration, penis, scrotum, and pelvic area. You know, just remember how that lymphatic drainage is, so you can imagine where that black and blue is going to go. Some patients will really get freaked out by it, but I think as long as they know it's normal, it's not something, you know, if they're bleeding inside, it's just that's the normal drainage. It helps. As healing occurs, pain will gradually subside. A lot of these guys are pretty miserable right after the surgery. I can tell you that. It's not very comfortable to have all that. And you can imagine all the manipulation that's done to place those rods. So they're pretty sore. And we tell them it's normal to have pain and swelling, especially when standing. We also warn them that there's a certain amount of fluid that we leave in the cylinders at all times. This is to prevent formation of scarring on a completely deflated cylinder. So it's normal to like feel a partial erection. What you don't want to do is have it pumped up. Now, when we place the prosthesis, they have a lockout button that is engaged by the physician so that the pump only has, the cylinders only have so much fluid in them and you can't pump it. But you can, if you accidentally disengage that, you would be able to. And that's what we normally do on their first visit, is when we have them to teach them how to use it, is we disengage that button. Scar tissue will form around the penile pump. This is probably the most important part of patient teaching. Is it's going to scar, but we want it to scar where they can use it. It's got to be down low in the scrotal sac. Some patients are afraid to touch it, or they don't leave it. We tell them they have to pull this pump down every day, because otherwise it may scar up into the groin, like almost like where a hernia would be, and it'll be almost impossible to activate it and deactivate the device. So we tell them gently to retract the pump down in the scrotum every day. And if they just kind of find it, reach up, find it, and pull it down, they're not going to hurt it. Just grab it, pull it down. And again, early on, it's sore, so they tend not to want to do that. Also, it's imperative that the penis be maintained in a straight position. This involves keeping the penis pointed toward the belly button using tight-fitting underwear. So we always instruct them, wear the penis up, good solid support so it stays up like that. On the third day after the procedure, we recommend that they take 2 to 3 20-minute baths a day, no showers, to help prevent that swelling and tenderness. For the first 48 hours, they're generally told to stay in bed. Obviously, you want the dependent drainage. If they're standing, gravity's going to make things drain. It'll swell more down there. So we try to keep them on bed rest to minimize that swelling. It's not strict where they can't go to the bathroom, but it's just to keep them in that position. You should walk for about 15 minutes 3 times a day after that. You don't want them to be active. You don't want them to just be laying around. Otherwise, you're risking such things as blood clots in the legs. So there's really 2 major players in the prosthesis world for inflatables. And the one is the 3-part, which is shown here. So you've got your reservoir, your pump, and your 2 cylinders. So that's considered a 3-part. There has been some looks at trying to make this easier by putting just 1 reservoir and pump in one, so that you can pump it up with just having this 1 scrotal pump and no reservoir implanted elsewhere. I couldn't find a picture of it, but we used to have one that you could actually squeeze the tip right up here. All you did was implant the 2 rods, and the entire thing was right within the rod. So you would squeeze the tip up here, it would pump itself up and get hard, and you would just then kind of like bend it over, and that would release the pumping mechanism and it would get soft. I thought it was a pretty cool design. But I can tell you that aesthetically, this was the one that most patients liked the results the best. It was the most natural looking erection, where the other ones don't quite get as much. Most of these prostheses go from soft to hard. Normal erection, you get girth. Some of the newer ones do get a little increase in girth. There are some that actually will increase a little bit in length, and it's not to make the penis bigger, but sometimes it just fills out better. Remember, these corporal cavernosal rods only go up to the tip of the penis. They don't get to the very head of the penis. So sometimes patients notice a little bit of a floppy tip on their erection from that. So some of these are better. Those all-in-ones didn't really do anything more than get hard and soft. So at this point, we're going to switch gears here and go into the vacuum erection device. The history of the vacuum device: 1874, the first clinical application for a vacuum technology for erectile dysfunction. Didn't really work too well, because it wasn't until 1917 that Dr. Lederer combined suction and compression. So that's really what's necessary. So you can make the cavernosal bodies erect by external vacuum pressure, but it won't stay erect. So you need something to kind of clamp down and stop those veins from letting the blood drain. And so that's what he came up with. Interestingly, though, from 1917 to 1970, the device was barely altered. It really wasn't utilized much. Nobody kind of did any great studies and changes to the device. So it either was so good or so bad, right? Excuse me. So external vacuum therapy really kind of got its kick in the butt by a guy by the name of Gettings Osborne, who was using it to treat. He kind of dug up that old patent and dusted it off and did some updating to it and created what he called the Erectile system and formed this company that would produce the erection device that we currently all know, the vacuum erection device, which was a pump and tension rings to help maintain an erection. And it was in 1982 that the U.S. Food and Drug Administration finally granted permission for the VED as a prescription product. So when these first came out, and they're no longer prescription, they're over the counter. But when they first came out, these things were all prescription only. Now, I entered the urology profession in, I think, around 85. So, it's just a little bit after this had gotten its go ahead into the become a prescription device. And I can tell you that I got recruited by my group to actively start, helping patients that were interested in it and how to use the device. So I got a lot of hands-on experience. And again, that's what I say. That's what we bring is hands-on experience. So in 1980, Weatherington and Natick and in Lou in 1990, basically kind of helped push the device's usefulness to gain recognition. And in 1991, it was the most prescribed treatment for ED. Remember that the pills didn't come out until much later. So it was the king, and I think if you think about it, if you go to a patient and you said to him, well, you've got an option. We can, do a surgery, put a penile prosthesis in, or you can use this little suction device and you'll get an erection that way. Most patients are going to want to at least give that a try. And most of our physicians always would recommend try the vacuum device. If you don't like it, then we can talk about the penile prosthesis. What were some of the advantages and disadvantages? So advantages, it's quick to use. Normally an erection will occur in a few minutes. They say increased spontaneity. I don't ever try to tell patients there's any spontaneity. You're going to stop and like Arnold Schwarzenegger, I'm going to pump you up. It's not something that you can just kind of spontaneously use. You can't hide the fact you're using it. It's a pretty obvious device, but it works. It's reliable. When taught properly, I would say that, there's probably 99% of the patients that can get an erection with it. Now, so it's easy to use. Again, some tricks to it. I will tell you that we're going to go through some of those. Totally non-invasive, that's for sure. Can incorporate into foreplay. The most success I have, I've always told patients, make this part of your whole foreplay. If you incorporate it, it's going to be a natural thing to do. You're just going to get going. It kind of gets some blood flowing to the penis, which is always good. If you take a totally flaccid penis, it's harder to work with than if it's partially erect. So if somebody's getting a little bit of an erection ahead of time, it's a big plus. One-time cost. Now, back in the day when these first came out and they were prescription only, I believe they were $500 a piece. And I'll go over some of the pricing now and some differences in what you can get for the money for the over-the-counters, which are still the same product, just much cheaper. But yeah, they were kind of expensive back then. But I can tell you, we used to buy them in lots because we got a discount to get them in bigger amounts. Few contraindications, priapism, if they have a known history of that, or significant bleeding disorders. And I would even go as far as to say that you can use it with patients that are on blood thinners, but you better do a lot of teaching. They have to use it carefully. You can develop a pretty serious hematoma on the penis from a vacuum device. And that's a scary thing. Usually not a bad, something that won't go away, but it gets patients pretty nervous. Disadvantage, instability at the base of the penis causing pivoting. So that's the one problem with the normal erection. Part of the erection is back inside the body, but the bands are always at the outside, the exterior of the body. So I'm trying to show that. So what happens is at the point where the bands are, the penis can pivot. So they have to kind of sometimes hold it to it, insert it, and just understand that it can pivot at the base. Usually once it's inserted, it provides a good erection for intercourse, satisfactory for both couples. With a few exceptions, they need to know that it's going to be a little bit bluish and cyanotic. and a cool erection. Some of the partners have said, yeah, the penis feels a little cool to me. Perfectly normal, not to worry about it. The inability to ejaculate is due to urethral obstruction from the bands that you're wearing. We'll go over those bands a little bit. You'll see that. Pain due to suction or constriction. Especially some patients are just, they're gung-ho. They put their penis in, they want it fast as possible, and they pump it up as quick as they can, and the results cause a lot of discomfort. Petechiae is pretty common, 25 to 39%, especially if they're on like daily aspirin or something. You'll see these little dots. That's really not a contraindication to using it. I normally tell patients wait till it clears up before you use it again, and be more careful with how fast you pump it up. Bulky, indiscreet, and messy with lubricant. So, I mean, you have to use a fair amount of lubricant to form good suction. And so for some patients, it gets to be a little bit of a daunting task, but usually I've never had a patient complain too much of that. So here's what the device looks like. This is the Encore device. So it's the cylinders. These are the bands that's shown here. And this is, get the picture out of the way. The actual vacuum device. That's the quick release that this one has. This is one of my favorite ones, by the way. It's the Encore. Comes in 3 different models, the battery operated and 2 manual ones. So this is going to show you how this works. So this quick release valve is placed or release sleeve is placed on the vacuum device, and it's got a loading cone. Put a little lube on the cone. This is the hardest thing for most patients, is to get that band on the vacuum device. So you have to preload the band so it's able to be snapped off right away. And then this is the vacuum erection with the electric device. So it's a battery operated suction device. Something they came up with. I think it's not a bad idea. One of the problems is if you don't get a good suction around the penis, it won't work. So they got this rubber gasket sort of device that you can put up against your body. Sometimes you can use less lubricant that way. But the whole trick is then you push the button, and this button has to be held. That's not the way exactly how they show, but you hold the button so that you're controlling the amount of vacuum pressure. I tell patients till it gets uncomfortable, don't overdo it and give it time. Not as fast as this guy in the demo shows. So there he just pushed off the band. This is, they call it the one-hand manual pump. I kind of like the manuals myself. I just think that they're more reliable. You don't have to worry about, if your battery's not charged, you're not charged either. So this is a 2-hand model, both easy for patients to use, dexterity. Once you obtain the erection, that extra piece is removed. You don't need that on during intercourse. And then you do wear the band around the penis to maintain the erection. So that's why if you ejaculate, there may not be any semen coming forward until you pull that band off, and then it'll just drip out the front. And you should never wear the ring for more than 30 minutes at a time. You can tell them you can have sex every hour if you want, as long as you take an hour off in between and not leave it on for more than 30 minutes. So lots of choices out there. This is Amazon's website, and the most expensive one, I just kind of wanted to get a variety, was $200. Remember, it was $500 when it was FDA device approved, but for the low cost of $200, you can get the Augusta model. The Encore model, the one I demonstrated, which I kind of like, they actually give you a combination of the electric and the manual. I think that's a pretty nice way to do it. So you get the whole thing for $125, and it includes the bands you need. We'll talk about that, a DVD on how to use it. Plus, I like that quick release mechanism. I'm going to show you that in a little bit. But patients can get it for as cheap as $37 for a electronic model. It's this Amazon's bestseller. And then $12.99, this really El Cheapo with this manual device. Now, I will warn you about what's the differences. So I recommend to patients that I would go with the Encore device. And the big difference is the amount of vacuum pressure that these things can create. This one and this one are not very regulated pressure systems. So as hard as the patient can pump it, and probably too hard sometimes, they can build up a lot of pressure. All devices have a release mechanism. So if you over pressurize it, you can push a button or let the pressure out. But again, I get a little worried with these, I guess the old, you get what you pay for, right? These two devices I'm a little nervous about. I would recommend at least spend the $125. I don't see a big advantage of the Augustus system. It has nothing that the other ones for $125 or $75 less can offer. But the truth behind it, excuse me, is it's all about the rings. So most of these vacuum devices will get you an erection. It's how you maintain the erection and what's comfortable. Some of the rings are not very comfortable. Some are not very good. So I like this particular set. It's a silicone, and you can see they come in all different sizes, and you have to figure out what size works best. I always start with the biggest diameter one, and then which would be this one, size 3, then work my way down smaller until it's strong enough to hold the erection. And patients, you have to experiment with this. You need to start off, don't even use the rings, just kind of practice getting the erection. After that, start with the big ring. Does it hold it? Nope. Next time, give it an hour break, try it again, or next day, next event, try it again, use a slightly smaller ring. I really like this kit. It's a little pricey, $110, but it gives you a big variety of ring choices. And I think that you're not going to find one ring that everybody's going to have a great success with. But I think this will give you, and you can see that some of these are smaller inner diameters. And I can tell you some of these small ones are really tough to get on that cylinder beforehand. So these are all 4 different types of materials, silicons, and I don't know what this other one's made of, but I think for $110, it's not bad. Otherwise, there are all the devices come with some of their own bands, so you can try and see what they come with. Now, Tim Medical, as part of the Osbond, came up with this erection tension rings. And what they did is they put these 2 little bumps here. Those are supposedly to compress the veins so that they don't leak blood out. So that's the bumps there. And then underneath here, they made an opening to relieve pressure. And their claim to fame is that you should be able to ejaculate through that. I could tell you that I've worked with the bands with patients, and I don't think they're as efficient at preventing the blood from just leaking out, so they don't hold the erection as well. I haven't had any patients say they noticed better ejaculation with them. And I think those bumps sometimes make them uncomfortable for patients. So I'm not a big fan of them, but it's out there. You're not the one using it. Give the patient the options when you're teaching about it. And then this was a set I saw. I'm not even sure about, just looking at how bulky that is, how good it would work. But I think the idea behind it is it's a seal that'll form around the vacuum device, and then the inner ring is built into it. So I think some patients have trouble pushing that ring off. So this might be something that works for them. So you have to have lots of options. This is not something that you just tell the patients, go to Amazon and order it. My way that I like to do it is I would tell the patients, go to Amazon and order this particular one. I would give them a printout of it to take home, and then make an appointment to see me and bring the device in. We're going to go through it step by step. I always say that 5 minutes with me is worth hours and hours of struggling with the instruction sheet. And I've had really good success with patients, but I think it's something that you need that training and then the expertise. Here's his struggle. I go, well, let's go and order these. Let's see how that works, because you can't push that band off. And then, as I said, it's always best to start with the largest diameter and then work your way down. I've gotten to the point where some patients have to use 2 bands. That's acceptable, long as it's, it's holding the erection. That's the main thing. So some patients will have to have tighter. Most patients don't. I usually find most people kind of fall in this middle of the road type bands, like right around here and here. Very few have to wear the smallest. Very few have to wear the biggest. Now, if you ever really wondered if I was an art major, here's the answer to that question. When I was trying to come up with, I couldn't find anything on the internet. A problem that's real common that I see, and it's frustrating for patients, and it's the penis gets actually kind of like bent on itself as the pump. So you're pumping your penis up, it's flaccid, so it just kind of drags along this surface as it's starting to enlarge. And at some point, it'll probably get caught and start bending over. So the bodies are still filling, but now it's bent in half. They're not going to get an erection if their penis doesn't get fully erect. They have to get all the blood they can into it. So I come up with what I call the double pump method, or the break, shake, and reinflate. Now, what I mean by that is you pump it till you start seeing it, bending, and you still have some blood in the penis. Then you break the seal. So you go ahead and push that button to relieve the pressure. You want to literally, sorry if I just hit my mic, literally shake the device up and down to get the penis to kind of lay flat into the device. Sometimes if you're having a lot of trouble, put a little lube on the tip of the penis so that it slides better, but you want to shake it down into the cylinder and then go ahead and reinflate it. And it'll then get fully erect. It really saves again, that's why I say 5 minutes with me will save you hours of frustration, because I can see what's going on. I know where the problems are. I'll warn you about it. The other big thing is patients are not patient. They start to see the penis get erect. They're ready to go. So what they do is they start to inflate it. It's a little bit erect and they want to pop that band off. I tell them, you've got to make sure you have 100% erection. So the way you can judge that is while your penis is in the cylinder and you think it's erect, give it a little bit more suction. So if it's the button for the electric or in the pump for the hand, give it a little bit more and watch the penis. If it increases in girth or size, then give it a little more time. Most patients, like I said, they in 1-2 minutes, it looks like it's erect, but it's not. You have to trap the maximum amount of blood. Otherwise, you're going to get an erection that when it comes out, it's going to be half erect. So you've got to have 100% filling. So encourage them to take their time with it. And then this is the most important thing. You have to push the band off quickly. You got to get all the band off of the cylinder, and it's got to completely come off before the seal breaks. Because once it clamps down on the penis, you'll hear the suction of the rush of air coming into it. Rarely, depending if somebody has a pretty good sized penis, they're gonna have to release the vacuum with the push button. But most of the time, it's going to break the seal. So if you get like half on and half off, I've seen that a lot. They're going to have a half an erection. So this is why I like this device so much. This little twist thing right here. So when you twist it, it pushes on both sides of the band, or 100% of the band, all the way 360, and shoves it down to get it seated before the vacuum breaks. Really, really works well. And it's so easy to use for patients. That's the best part. So here's another one of my artistic drawings. I couldn't find a good picture, so you get my nice drawings here. So this is the penis inside of a vacuum device. And we got to remember about the scrotum, because it's right down there too. So I always tell patients, grab a hold of that thing and pull it down, especially when you first start suctioning it. Because if not, I've seen this happen and it's not a good thing. You can pull a testicle right into the vacuum pump, and it's very uncomfortable. I mean, you can imagine it's pretty uncomfortable for patients. At that point, break the vacuum, restart it. But if you tell them to grab their sack and pull it down as they're vacuuming, that's why I like the electric ones the best, because it's got a one hand or that one-handed manual one, so that you can pull with one hand, vacuum, get it started. Once it's kind of set and started and the vacuum is well established, it's not an issue. And then these things here help to make that inner diameter narrower. So if you are getting a lot of trouble with the scrotum falling in, make sure you put the reducing rings in. If it's too small, it'll be hard to get off. So make sure you start big and then work your way down. So tips and tricks. Best using standing up. Trim or shave pubic hair. Gets in the way. Use plenty of lube. I always say put it like you're putting toothpaste on your toothbrush, a ring around there. Keep the lube off of the scrotum. Otherwise, it makes it easier for the vacuum to suck it in there. Be patient. Huge. Got to be patient. Only pump until slight discomfort. Don't go crazy. Some patients are just they're bumping and pumping and pumping, and you just tell them, hey, easy. It's the pressure that's doing the work, not the pump. So they should never use it if they're having, they notice their skin is broken or bruised. The vacuum device has found its way into some after prostatectomy penile rehabilitation too. So use of drugs or devices can help maximize erectile recovery. They think that, by getting that continued blood flow and tissue oxygenation, it can prevent smooth muscle structural changes. So we can advise patients to do a penile rehab with a vacuum device. No rings necessary. All you're doing is just getting it erect. Use daily for about 10 minutes without the tension rings. Significant decrease in penile size after radical prostatectomy has been a common complaint. So we can see from these statistics that men have noticed that their penis is not as large. And we do know that can happen. So it is also being utilized as a penile shortening treatment, vacuum constriction therapy. We can see in this study that it showed that there was better penile length preserved for those who did it after radical prostatectomy than those who didn't. So again, it's got other reaches besides as an erection therapy. So that's the end of my presentation. And this is your chance to ask questions. Feel free to send those in anytime now.
While people are sending in their questions, thank you so much for that presentation. That was so informative. I mean, this is just such an area where experience is super important. I do have one question because I don't generally treat erectile dysfunction in my own practice. We have a specialty or a specialist in our clinic. Can you combine oral agents and the vacuum device?
So you can, and there's some studies that have advocated doing it. Kind of makes sense. I think the more blood you get flowing into the penis, the better. So I think I kind of have two thoughts. Number one, if you're using a vacuum device, you probably don't need the drugs, and they do have side effects. So there's probably some argument to not doing it, but there's really no reason you couldn't. You're not going to increase risk of priapism or anything by combining them. I've had many patients who say they do use both and are happy with it. So it's an option, definitely. So I think we have one question that came in here from Rebecca, the cartilage transplant. So I'm not sure what the
I can give some light on that. So Rebecca had asked how long until it's reabsorbed.
Yeah, I think it was reabsorbing in the course of a few years. So it wasn't instantly reabsorbed. I'm trying to remember, I read the research a while back. But the big problem is it had all this infection and scarring. So they said that most of the erections that they came up with were curved. So they had the first 4 months, it was too sore to do anything with. After about 4 months, patients were able to have sex with it. So it did work. They were satisfied, but then there was always the issue of either reabsorption or scarring down the line that led to it not working very well. Neil Smith's got a question here. You want to read it? Can you see it?
Yes, from Neil Smith. For IPPs, how long are these lasting for your patients before they require replacement? And what part of the device fails or wears out first?
Good question, Neil. So it's kind of unknown. Early on, I used to tell patients that, most of these would fail in about 5 years. Now, that was early on. And of course, I told you I started in urology like in 1985. So back then, penile prosthesis was still in somewhat its infancy. But the newer ones are much more reliable. The failure points typically tend to be leakage. So there's a bunch of connectors. That's one of the things in the surgical procedure that's changed now is there's less connectors and better connectors, but a lot of times those would break down and leak. And then the second most common thing was the vacuum pump itself. The pump itself, the one in the scrotum, it's a mechanical device. It's got some valves and things that have to function. And when those stop functioning, you can't pump it. And that was a patient that I had that had a penile prosthesis that had not leaked, but the pump failed. And he didn't want to go through surgery again. So he wanted to try a vacuum device. And it was surprising. It worked, but it didn't, you can't compress with the rubber bands, the device to prevent leakage out through those tubes. So what he could do is it was a slow leak. So once he got it to fill, he could have sex until it kind of went down, but it did work. So it is an option. It can actually pull some fluid into the cylinders again.
Thanks, Vic. We have another question from Susie Swain. What is an indication that a penile implant is starting to get infected?
Yeah, I think back to those pictures that I showed, it's pretty obvious. You'll see something protruding, some foreign body coming out through the penis, the scrotum, the tubing on the side. Obviously, early on, the signs and symptoms of infection, redness, swelling, fever, those type of things are things you look for. But the almost always patients will come in, you can see a little bit of prosthesis sticking out the tip. It's usually those two. The most common failure is at the tip of the penis where those rods are placed. I think that, some physicians maybe didn't size properly. I don't know that if that's why it happened or what the actual rationale for it is, but that's where I see it the most.
Thanks. We don't have any questions currently, but I just had sort of a thought. I know, erection or erectile dysfunction can indicate that there could be a cardiovascular problem. I've even seen some providers who will refer patients to the cardiologist as soon as they're noting erectile dysfunction, as long as there's not a neurologic cause that's identified. I'm not an expert on the literature with plant-based diets and erectile dysfunction, but I did a quick search. I see a recent study here from March of 2022, and they found that in well-characterized national database, they showed that healthful plant-based diet is associated with less chance of having erectile dysfunction. Whether interventions with a plant-based diet will improve erectile dysfunction remains to be studied. I'm wondering if you've seen any patients in your practice who used a vegan or plant-based diet for their erectile dysfunction, if they had any improvement.
Yeah, that's a good thought. Good question. I don't know of any patients personally that have sung the praise of a vegan diet, but it does make a lot of sense. All the literature that I've read has said anything that's a heart healthy diet is a penis healthy diet too. As I kind of talked about in that first presentation, part one, the vasculature, the heart vessels are much bigger than the penile vessels. So the arteries in the penis are much smaller. So it makes sense that if you're going to start having problems where they block your heart, they're probably already blocking the penis. So sometimes it's the first warning sign is of erectile dysfunction is that the first warning sign for heart disease. So they should always be addressed both things at the same time.
Yeah. Sometimes if I have a patient in the clinic complaining of erectile dysfunction and I see that they're currently smoking, I'll just do a brief smoking cessation education for them as well. We have another question that came in. If a patient undergoes explantation of an infected implant, can they have a new IPP implanted in the future? Or does this exclude them from penile prostheses? Yeah,
no, we have reimplanted down the line. So they can have another penile prosthesis. Of course, the infection has to be completely cleared up. And when you take out a penile prosthesis, you just got, a urinating device. That's it. Because there's no erectile tissue really left. It's kind of been, reamed out with the prosthesis. So, yeah, if infection, that's good. That's why I say it's such a disaster, why they took all the precautions when they worked in the OR. That was like the cleanest room that you had. They had no infected cases done before that. They're usually the first case of the day. They had a whole protocol that they went through to make sure that this was as sterile as possible.
Yeah. And I think most providers are now, if a patient has diabetes, they're requiring their hemoglobin A1C to be at a certain level.
Yeah.
I think it's usually less than 7% to help prevent any issues with those infections.
Makes a lot of sense. And of course, those are the people that are having high risk of infection high risk of erectile dysfunction because of the high sugars damaging those small nerves that are involved in erection. So you got the Pandora's box. You got somebody who's at high risk for healing problems for the cure, and they're the ones who need it the most.
Yeah. No questions on the Q&A box currently. Oh, here one came through. Given the hardware replacement for an IPP, can a patient have both an IPP and artificial urinary sphincter placed? If so,
Absolutely.
could they be done in one surgery?
Yeah, that's a great question. Thanks, Neil. That's actually one of the largest things that our group has done is radical prostatectomy patients got incontinence and they have erectile dysfunction. You can go in there and put in a prosthesis and the treat the incontinence with a prosthesis or a sphincter. I'm sorry, sphincter for that. So they can be done as a one-time operation with both devices implanted at the same time, and they work really well. The nice thing with the devices, they both have their own pump device, so you can utilize one scrotal sac for each device. They have their own, they would have their own separate. Well, this has been a great discussion. I'm really impressed with the questions that came in. I'm glad to see everybody. I see all the names showing up here. Lots of people that have been here before. Glad that you're following us and staying with us here. Claire, Diane, Jackie, Leo, Monica, Neil, Olive, Rebecca, Rochelle, and Susan. We are going to have, as always, we're going to have the after party. So if you want to ask further questions or just sit and chat about something, we'll have the after party available. Otherwise, there's no other questions. I'm glad to call it a day. We had a nice full discussion. I really appreciate your help, Andrea. That was great. Looking forward to your talk for next week.
Yeah.
So should be good. So, Monica, thank you. Great talk. I'm glad you liked it. Again, I think it was kind of fun to dig into the history. That's one of the things that I enjoy giving talks, because in a lot of this material I've had for years, I've done a lot of these talks in the past, but I always do a little more research just to see what what's going on. And it's fun to do the research and see how the history came out. So it's all good. And who knows what's going to be the future too. That'll be the next thing. How you can treat erectile dysfunction in a way we probably never even thought of. So, Rebecca's excited and maybe hear more about the PureWick next week.
Yes, I need to do my research because I haven't practiced yet, but a lot of patients are asking about it. So I'll prepare for next week.
There you go. No pressure. All right. Well, everybody have a great, wonderful fall day. It's bright and sunny here in Chicagoland. Hope you got nice sunny weather. Leaves are falling. It's getting chill in the air. So winter's coming upon us. For those of you that are coming to the after show or want to go to the after show, go to euronurse.com. Just click that after show button. We'll see you there. Bye-bye. Have a great day.